Urinary incontinence is the involuntary leakage of urine. It is also called overactive bladder. Urinary bladder is a balloon-shaped structure with the outermost muscular layer known as detrusor muscle. This detrusor muscle and the bladder outlet functions are neurologically coordinated to store and expel the urine. The detrusor muscle is innervated by parasympathetic nervous system and contains abundant amount of muscarinic type 3 and type 2 receptors. These receptors, when hit by acetylcholine under the influence of parasympathetic nervous system, causes contraction and expulsion of urine. Moreover, the bladder neck sphincter is innervated by sympathetic nervous system and contains receptors such as beta 3 and alpha receptors. These receptors, when hit by noradrenaline, causes the detrusor muscles to relax and store the urine. So it has opposing action. Moreover, the external urethral sphincter is innervated by somatic nervous system and is under the influence of voluntary control. In case of overactive bladder or urinary incontinence, there is inappropriate stimulation of muscarinic receptor present at detrusor muscle, causing involuntary contraction and urinary urgency. There are different types of urinary incontinence based on the signs and symptoms. The first one is urge incontinence. It is a type of incontinence where there is a sudden and unstoppable urge to urinate. It mainly happens because of neuropathy, happens in conditions like diabetes, Parkinson's, multiple sclerosis, and dementia. The second type is a stress incontinence where urine leaks during any kind of exertion, such as coughing, sneezing, laughing, and many more. The third one is a combination of both stress and urge incontinence called mixed incontinence, while the final one is overflow incontinence, where leakage happens when the quantity of urine stored in urinary bladder exceeds its normal capacity. It happens particularly in conditions like benign prostate hyperplasia. Treatment of urinary incontinence involve both non-drug measures as well as drug measures. Non-drug measures are considered first line to improve urinary incontinence symptoms. These include behavioral therapy such as bladder training, delayed or scheduled voiding, pelvic floor exercises, moreover urge control techniques and distraction. Similarly, weight control can also decrease the signs and symptoms associated with urinary incontinence. Before going to drug therapy, it is important to highlight and address any underlying drugs which can cause or worsen urinary incontinence. These include diuretics, cholinesterase inhibitors such as donepezil, alcohol, and many more. Drug therapy involves the use of three classes of medications. The first one is antimuscarinics or anticholinergics, second one beta 3 agonist, while the last one is botulinum toxin. Anticholinergics or antimuscarinic agents produce its action by competitively binding to the muscarinic receptors present on detrusor muscles. Hence, they block acetylcholine from binding, and as a result, there is limit on the contraction of detrusor muscle. Drugs which belong to this class are classified into older agents such as oxybutynin with immediate release formulation, extended release formulation, and patch formulation. The newer agents have fewer side effects and include agents such as sulfasenacin, darifenacin, and phytotyrosine with usual doses given in the brackets. These drugs, however, are contraindicated in conditions such as narrow angle glaucoma because it can worsen it. Side effects are obvious since these are anticholinergic agents. As a result, they should cause conditions like xerostomia, that is dry mouth, constipation, and blurred vision. The patch formulation or extended release formulations are preferred as compared to immediate release formulation when selecting the older agents because there is a lower risk of dry mouth. Moreover, the newer agents are preferred as compared to older agents because they have fewer side effects on central nervous system such as drowsiness and dizziness. It is important to note that These agents should not be used in patients with more than 65 years of age because of conditions and risks like delirium and cognitive impairment. Beta 3 agonists are another class of agents which binds to beta 3 receptors and hence relaxes detrusor muscles. This activation of beta 3 receptors followed by relaxation of detrusor muscles increases the bladder capacity to hold urine. Drugs which belong to this class are mirabegron and vibegron. Both of them have similar efficacy, however mirabegron have lower side effects such as dry mouth. These agents can be used alone or in combination with anticholinergic agents. When used in combination, it is important to monitor the blood pressure because it can increase the BP. Mirabegron have side effects such as angioedema of face and it is a moderate inhibitor of CYP2D6. Therefore, caution should be exercised when used in combination with agents which are substrate of this enzyme, such as metoprolol. These agents show its effect within 8 weeks almost. Botulinum toxin or Botox is the third line treatment for urinary incontinence. They are actually neurotoxic protein produced by bacterium Clostridium botulinum and they block the release of acetylcholine and its function. They come in injectable form and given at a dose of 5 units across 20 sites. Its maximum dose is 360 units in 90 days. While they are effective, but they are highly costly. A stepwise approach is recommended when treating patients with urinary incontinence. This includes starting with behavioral therapy and followed by anticholinergics or beta 3 agonists based on severity of symptoms as well as patient conditions. Drugs which have more side effects should be avoided and replaced by agents such as gel or patch formulation with lower side effects. Similarly, beta 3 agonists such as mirabegron have lower dry mouth side effects and should be used. It is important that once a therapy is started, it should be allowed for at least 8 weeks before changing or modifying it. If these agents fail, then the second option is basically botulinum toxin. However, this is injectable formulation which requires injection as well as painful and expensive. If patient is unable to respond to both behavioral therapy as well as botulinum toxin, then the last resort is neurostimulation or surgical treatment. If you found this video useful, kindly like it and subscribe. Thank you.